إخواني وأبنائي أطباء العيون، السلام عليكم. In this session I will continue the discussion on the management of uveitis, the stepladder approach, and I will outline some important practical points in the management of retinal vasculitis, focusing on the diagnosis, causes, and the treatment. Retinal vasculitis is an inflammation of the retinal blood vessels and can be associated with various infectious or autoimmune disorders, systemic or ocular, or can be as isolated idiopathic non-specific retinal vasculitis. Masquerade retinal vasculitis are cases with clinical signs similar to retinal vasculitis, but are not caused by inflammation and are resistant to treatment with anti-inflammatory drugs. Examples of such cases are neoplastic disorders, intraocular lymphoma, and leukemia. Diagnosis of retinal vasculitis is made with the clinical signs and/or with fluorescein angiography. The classical clinical signs of retinal vasculitis are perivascular sheathing and perivascular coughing. Perivascular sheathing in active vasculitis appears as perivascular hazy white lines, consist of inflammatory cells infiltration, while in a chronic or inactive stage appears as perivascular well-demarcated white lines of sclerosed blood vessels. Perivascular coughing is perivascular yellowish-white patchy coughing of the blood vessels, consists of accumulation of exudates, sometimes exuberant perivascular exudation with the drops-like extension of the exudates to the adjacent retina called candle wax dripping, seen in severe types of retinal vasculitis such as in sarcoidosis. While a frosted branch anginitis is a florid perivascular cells infiltration involving the whole branch of a retinal blood vessels, seen in some cases of cytomegaloviral retinitis, retinal toxoplasmosis, and in Masquerade syndrome. Retinal vascular sheathing is not a pathognomonic clinical sign for retinal vasculitis. Retinal vascular sheathing or coughing may be not present in early or mild cases of retinal vasculitis. At the same time, retinal vascular sheathing can be seen in hypertensive diabetic retinopathy and in old retinal vascular occlusions. The hallmark finding of retinal vasculitis on a fluorescein angiography is vascular leakage of the dye due to damage of the tight junctions between the endothelial cells. Vascular leakage on fluorescein angiography is also not a pathognomonic sign for retinal vasculitis, as it can be seen in other cases such as hypertensive, diabetic retinopathies, and in retinal venous occlusion. Retinal vasculitis, as an inflammation of the retinal blood vessels, must be associated with signs of intraocular inflammation, such as vitritis, retinitis, or choroiditis. Isolated vascular sheathing without signs of uveitis may represent non-inflammatory vascular diseases, such as diabetic or hypertensive retinopathy. Therefore, the diagnosis of retinal vasculitis requires the presence of vascular sheathing or coughing and/or vascular leakage on fluorescein angiography in conjunction with the presence of other clinical signs of uveitis, such as vitritis, retinitis, or choroiditis. Most important causes of retinal vasculitis in our community are TB toxoplasmosis viral retinitis as infectious causes, Behçet disease, connective tissue disorders, and multiple sclerosis are systemic autoimmune diseases. Vasculitis, Ehlers disease, white dot syndromes are specific ocular causes of retinal vasculitis. while idiopathic retinal vasculitis is isolated retinal vasculitis not related to infectious or autoimmune systemic disorders and has no ocular signs indicating specific ocular disease. Diagnosis of the causes of retinal vasculitis, according to the Stepladder approach for diagnosis of uveitis, is in 4 steps. Step 1, history of present eye complaints. Step 2, ophthalmic examination, which is the cornerstone in the diagnosis. Step 3, systemic manifestations. Step 4, investigations directed according to the clinical features of uveitis. Regarding ophthalmic examination for the diagnosis of the underlying etiologies of retinal vasculitis, we have 2 important criteria. The first criterion is the clinical features of retinal vasculitis, type of vasculitis, involving the venules, arterioles, or both. Second, site of vasculitis, diffuse, peripheral, segmental, or focal. Third, nature of vasculitis, whether occlusive or non-occlusive. The second important criterion is the associated clinical ocular signs, such as vitritis, choroiditis, retinitis, retinal necrosis, cotton wool spores, retinal exudates, and aneurysms. In most cases, retinal vasculitis predominantly affects the venules, although simultaneous involvement of the arterioles and venules may occasionally be observed. However, in specific entities such as acute retinal necrosis, Irvine syndrome, and connective tissue-related vasculitides, arterial involvement is more characteristic. Site of retinal vasculitis is an important feature in identifying the underlying etiology. For example, diffuse vasculitis in Behçet disease, segmental vasculitis is usually seen in TB and sarcoidosis. Focal vasculitis is seen in most cases of retinal toxoplasmosis adjacent to focal retinitis, while peripheral vasculitis is seen in paraplanitis, Ehr's disease, and multiple sclerosis. Another very important clinical feature of retinal vasculitis in identifying the underlying etiology is the nature of vasculitis, whether occlusive or non-occlusive. For example, TB, toxoplasmosis, syphilis, and viral are occlusive, infectious causes. Behçet disease, paraplanitis, and Ehr's disease are occlusive, non-infectious vasculitis, while brucellosis, bartonella, VKH, and sarcoidosis are non-occlusive retinal vasculitis. All cases of retinal vasculitis are associated with vitreous reaction, except in immunocompromised patients with cytomegaloviral retinitis, connective tissue disorders, white dot syndromes, and Ehr's disease. In these cases, there is mild or no vitritis. Associated ocular inflammatory signs with retinal vasculitis provide valuable diagnostic clue to the underlying etiology. For example, the coexistence of retinal vasculitis with retinitis is seen in retinal toxoplasmosis, Behçet disease, and acute retinal necrosis, whereas retinal vasculitis associated with choroiditis is frequently observed in TB uveitis, syphilis, and sarcoidosis. In connective tissue disorders, cotton wool spots are common finding with retinal vasculitis, while the presence of retinal necrosis is highly suggestive of acute retinal necrosis or cytomegaloviral retinitis. Next step in the diagnosis the etiology of retinal vasculitis is systemic manifestations, present and past. For example, mouth and genital ulcerations are the criteria of Behçet disease. Arthritis, vascular disorders, and skin lesions are the criteria of connective tissue disorders. Pulmonary symptoms may indicate TB or sarcoidosis. Neurological manifestations in multiple sclerosis, while immunodeficiency clinical conditions are the systemic manifestations of HIV and cytomegaloviral infections. Next step in the diagnosis, the etiology of retinal vasculitis, is lab investigations according to the stepladder approach. Step 1 requires in all cases, including CBC-ESR C-reactive protein and comprehensive metabolic panel. Step 2 standard investigations requires in most cases of retinal vasculitis, including fluorescein angiography, IGRA test, and chest X-ray. Step 3 target investigations selected according to the clinical pictures, including serology for toxoplasmosis, serology for syphilis, virus serology, NAA panel, ANCA test, antiphospholipid antibodies, thrombophilic screen, ACE and lysosomal level, CT of the chest, and magnetic resonance imaging of the brain. Fluorescein angiography is essential for the diagnosis of retinal vasculitis, for identifying its probable etiology, and for detecting possible complications. Fluorescein angiography shows vascular leakage in the presence of vascular inflammation, illustrates the type, the site, and the nature of retinal vasculitis. It also detects the possible complications such as macular edema, capillary non-perfusion areas, and neovascularization. The following slide summarizes the step-ladder diagnostic approach for the probable causes of retinal vasculitis in our community, which are retinal toxoplasmosis, TB uveitis, Behçet disease, vasculinitis, acute retinal necrosis, cytomegaloviral retinitis, multiple sclerosis, and idiopathic retinal vasculitis. Complications of retinal vasculitis are macular edema due to vascular leakage, retinal ischemia and occlusive vasculitis, causing new vessels formation, complicated with retinal and vitreous hemorrhage. The treatment of retinal vasculitis is according to the underlying etiology. In infectious cases, treatment must be started with specific antimicrobial drugs according to the causative agent, while in non-infectious cases, treatment follows a stepwise approach using three main classes of drugs. Class 1, systemic corticosteroids, are used as a first line of treatment, providing rapid control of the inflammation. But due to the potential side effects associated with long-term use, they should be tapered gradually and discontinued within few months. Class 2, conventional immunomodulating drugs, such as methotrexate, azathioprine, mycophenolate, and cyclosporine, are used in chronic cases to provide steroid-sparing agents for long-term disease control. Class 3, biological drugs, which are target immunomodulating drugs, such as infliximab and adalimumab, are used in refractory or recurrent cases not well controlled with steroids and conventional immunomodulating drugs. However, biological drugs can be used initially in particular cases of retinal vasculitis, such as Behçet disease and connective tissue vasculitis. The most important critical initial step in the treatment of retinal vasculitis, as in uveitis in general, is to exclude or adequately control the infectious causes before using immunosuppressive drugs, as starting with these drugs in the presence of active infection will worsen the disease and end with a blind eye, in addition to the systemic complications. The use of these drugs should be in close coordination with a rheumatologist to ensure proper systemic evaluation and safe management. The ophthalmologist is responsible for establishing the diagnosis, suggesting the appropriate class of the drugs according to the underlying etiology and severity, monitoring the disease activity, and he is responsible for tapering and discontinue treatment once complete healing is achieved. where the rheumatologist provides systemic evaluation and diagnoses the possible systemic disorders relating to the retinal vasculitis, and he is responsible for proper selecting and dosing for the immunosuppressive drugs, monitoring and management of their potential systemic side effects. Management of the complications of retinal vasculitis is with systemic or periocular steroids for macular edema, scattered laser phototherapy for the capillary non-perfusion areas and the new vessels formation, and with anti-VEGF vitreous injections for extensive new vessels formation and vitreous or retinal hemorrhage, while long-standing dense vitreous hemorrhage requires pars plana vitrectomy. في نهاية هذا السيشن أرجو أن أكون قد وفقت في عرض بعض الملاحظات العملية والمهمة في موضوع الريتينال فاسكوليتس، ولكم جميعا الاحترام والتقدير.